Okay, so last week we talked about management of bacterial infection and antibiotics, which is something almost every primary care provider uses very commonly. This week we're going to talk about the management of viral and fungal infections, most of our time admittedly with viral infections. And so there's a lot of repetition here, and that's okay. I know when I was learning this stuff, I had to hear it several times before it just rolled off my tongue. And if you don't need to hear it several times, if this is material that you're pretty comfortable with, you can just blow right past it. So no worries. But the first several slides here really are repetitive because, again, just like we discussed last week, the purpose of any what's the word? And I guess I was going to say antibiotic, like in a very literal sense, antibiotics are just anti-life, right? So we talked about antibiotics in terms of bacterial infection last week. Now, in the context of antiviral therapy, the same principle applies. Any therapeutic agent designed to treat an infectious agent is ideally designed to kill or inactivate that agent without killing the human that is infected. It's easy with antibiotics in terms of bacterial infection, and because bacteria are completely separate life forms. They exist independent of the human environment that they make sick. One of the big differences between viruses, which is your next slide, one of the big differences between viruses and bacteria is that while bacteria are separate and complete cells with numerous different features, viruses are not. Viruses are parasitic to human cells. Viruses infiltrate the host cell, in our case the human, and so once they get inside of our cell, they are part of our cell, and it's really difficult to kill them without killing the cell that they are in. So targets of treatment are a little bit different. Sometimes we can stop viral replication or at least abort viral infection by keeping the virus from being able to infiltrate the host cell. But more often, by the time we're even aware that there is a viral infection, the virus has already gotten inside the host cell. And then it becomes much more difficult to control for the reason that I just said. If you can visualize this, like remember, bacteria have a nucleus that has their own genome, their own molecular code. They make protein and they are encapsulated by both a membrane and then a wall. And then in the case of gram-negatives, an outer membrane. Viruses are not that. They are not completely separate, independent life forms. Like I said, they are parasitic. Viruses really are just a little bit of genetic protein whose has like one goal in their world, and that is to find a place to replicate. Bacteria are born, they have their own DNA, which is like their own brain, they have their own life mechanisms, and then they die. If you get a bacterial infection in your airway, like lining your airways, lining your bronchi, and the main stem bronchus and then the conducting airways, you have a columnar epithelium, you have squamous epithelium, and they're all cells. They're epithelial cells. They have nucleus, they have organelles, etc. When you say get strep pneumoniae causing streptococcal pneumonia, the strep bacteria don't get inside the cells of your airway. The bacteria just sit next to the cells of your airway. And mostly the reason you get so sick is that your own body's immune defenses try to kill off the strep. And then everything, all of the inflammatory mediators and exudate migrate to the area, and that's what makes you so sick. But the streptococcus itself never gets inside of your cell. So it's very, very easy to kill, and then it is debrided, and then that's that. And as long as we can do all that with medication before the inflammatory mediators kill the patient, then everything is good. If you get a viral infection in your airway, the viruses don't sit next to your squamous epithelium and columnar epithelium. The viruses get inside it. So then you're pretty much stuck with that virus until either the virus runs through its life cycle or your own immune system can inactivate it. Viruses, they're parasites. They are not complete independent life forms. All they are is a collection of either DNA or RNA. So they do have genetic material. They're DNA or RNA. They are surrounded by a viral membrane, and they have one purpose in life: to find a place to reproduce. And so once they get inside the cell, it just makes things a little bit difficult. There are a few targets of antiviral therapy, and they are listed here. Host cell infiltration. Like I said, if we can keep the virus from getting into the host cell in the first place, then that's awesome. Like if we know there's been an exposure and we can do something to prevent cell infiltration right away, that'd be great. This is one of the reasons, and believe me, we will look at this in much more detail, but this is one of the reasons it's so important to take the prophylaxis as soon as you have any form of exposure, like a needle stick, occupational, or even non-occupational exposure to HIV. If you know that you have a chance of exposure to HIV, you want to take the cocktail immediately because we're trying to prevent host cell infiltration. Some viruses are DNA viruses, and one of the ways that we can try to at least block their progression is by blocking DNA replication of the virus. A little bit trickier because they are inside the host cell by the time they do it. Protein synthesis and maturation. Not that viruses make their own protein in the same way that bacteria do, but the way really that viruses are able to replicate is they get into a human cell and then they use the human's mechanisms of protein synthesis to copy themselves and proliferate. And then after that virus has matured, it has to be ejected from the cell and go out into circulation, and sometimes we can interfere with that. So these are the primary targets of antiviral therapy. Keep this in mind as we proceed with the discussion. Okay, so these next several slides are very much a review from last week. Like I said, if you don't need to review it, just skip past it. It's the beauty of a narrated PowerPoint, right? So DNA replication is one target, the birth of two new daughter cells from one parent cell. And there are times that we want to block this process in terms of viral replication. So got a few pictures here. And if I'm not mistaken, most of these are pictures from last week. So here again, this is your Watson-Crick double helix. If you looked at this up close and personal under a microscope, you would see that these are base pairs, A, T, G, and C. They are anchored together by these phosphate bonds, and this forms the DNA that is in the nucleus of a cell. When it's time for DNA replication, a code occurs, and then a series of enzymes produce separation of the double helix and the synthesis of a matching strand, and then you have these two new daughter cells, and that's how some viruses, DNA viruses, manage to replicate. The process of DNA replication is detailed in these next few slides, and these might even be straight up copies of last week. Sorry about that. I don't know about you, but when I learn something new, I certainly don't remember everything I saw in a slide set. That's why I copied a lot of this over, because it's directly relevant to this week. So if you didn't remember, DNA replication is that process by which one cell divides to produce two new daughter cells. The genetic material contained in the parent cell is transferred to the two new ones, and these are masters. DNA is a master code. It is generally considered to be error-free or flawless, and you have two new separate independent cells. DNA is the genetic material. Now, this becomes a little more relevant when we talk about antiviral drugs, that you understand what makes up DNA. So DNA consists of a sugar base nucleoside with 1, 2, 3 phosphate groups attached. So a sugar, a sugar, C6H12O6. There's glucose, there's galactose, there is fructose. Those are your monosaccharides. So a DNA has a sugar, it has a base, which is your A, T, G, or C, and the sugar and base pair is referred to as a nucleoside. You'll want to remember that because some drugs used to treat viral infection are nucleoside reverse transcriptase inhibitors. If you add the phosphate groups that attach these nucleosides, then they become nucleotides. And that's relevant because we do have nucleotide reverse transcriptase inhibitors. I don't care that you remember all the specifics. I just want these terms to make some sense when we refer to them later. So your sugar base pair is a nucleoside. The sugar base with its phosphate group is a nucleotide. And replication, again, one last time, is the process by which two new daughter cells, two new masters, are formed from the parent. A series of enzymes are responsible for this. We talked about DNA polymerase, I think, briefly last week. DNA polymerase is among them, and we'll probably talk about DNA polymerase again this week. Okay, so here's our nucleosides and nucleotides. Sugar, sugar and bases. So here's your sugar. The green is your base, and then they're anchored together by phosphate groups. So you can have a nucleoside or a nucleotide. The only reason it really matters is because of the different mechanisms of actions of some of the antivirals. But you can see if you need nucleosides and you need nucleotides to be one half of the base pair, if you give the patient a nucleoside or a nucleotide reverse transcriptase inhibitor, it stands to reason that if you're inhibiting this, you're going to inhibit the ability to synthesize new DNA. The other process that we have to interrupt in the setting of viral replication is protein synthesis. And again, I know this is a repetition, but I just want to be very clear on the differences between DNA replication, the birth of two new daughter cells, versus protein synthesis, which is DNA transcription and subsequently translation. This phrase is considered the central dogma of molecular biology. Protein synthesis occurs when the code contained in the master DNA in the nucleus, when that code is copied or transcribed, it is transcribed into RNA, and that RNA is translated into a protein. And this is the way it's supposed to go. DNA is transcribed and then translated, and that makes a protein, and that is the way it's supposed to work. That's the natural order of the world. It's a unipolar action. It's a one-directional thing. It doesn't go backwards. We do sometimes get a little fly in the ointment because viruses are so adept at survival. But the way it's supposed to go is that you have the master code contained in the nucleus in the form of DNA, and when that code needs to be copied and expressed, the DNA unwind, you transcribe a single-stranded RNA copy of the code, and then, or you actually transcribe several, and then all of those transcriptions are translated in the form of a protein. This process last week too. Oh, I bet your slides just cut off there because I advanced the slide without stopping to take a break. So all I said at the end of that slide was that I know we talked about this last week too. These next several slides detail the process of protein synthesis, or DNA transcription to translation. Just like DNA polymerase catalyzes replication of DNA, transcription is catalyzed by a group of enzymes, including RNA polymerases. RNA, single strand. RNA is a copy. DNA is a master. They're not the same thing. Unlike DNA replication, protein synthesis is the process by which the genetic code in the DNA is interpreted to form a new protein, because it is, after all, protein synthesis. It's not about forming new cells. It's about sustaining function of an existing one. So I already mentioned this. Synthesis of RNA from DNA is called transcription, and this is all code-based, or signal-based. And then, like I mentioned last week, there are 3 types of RNA that have to be transcribed that all come together to translate into a protein. There's messenger RNA, there's ribosomal RNA, and there is transfer RNA. So the messenger RNA is transcribed from the DNA, and then it is edited, and then that messenger RNA migrates out of the nucleus into the cytoplasm. And here's a very old-fashioned picture of that, right? So the DNA unwinds. You transcribe the single-stranded RNA copy. This is the nascent or immature RNA copy. Then that immature copy is edited, and then you get the mature copy, and that is your messenger RNA, and the messenger RNA migrates out of the nucleus into the cytoplasm, specifically over to the organelle that we know as the endoplasmic reticulum, because that is the site of protein synthesis. Ribosomal RNA is another type of RNA that has to be transcribed. Unlike messenger RNA, it is not single-strand, and I want to clarify this here. It is originally copied from the DNA as a single strand, but then that strand is folded into those spherical structures called ribosomes that we talked about last week. And remember we said that humans have 60S and 40S ribosomes, and we were comparing that to bacteria, which has 30S and 50S ribosomes. So they are originally translated or transcribed as a single strand, but then it folds up to become these ribosomes, and the ribosomes also migrate through the nuclear pores, and they line up on the messenger RNA, and they connect and form this big ribosome. And then the transfer RNA, which is the last part of RNA, or the last type of RNA that is transcribed from the DNA, transfer RNA begins to carry over amino acids to this ribosomal assembly unit. So this picture just shows you the process by which you make a single-stranded RNA copy, but then that single-stranded RNA gets folded up into a ribosome, and they get edited, and in human cells you wind up with a 60S ribosomal subunit and a 40S ribosomal subunit. They form on the messenger RNA and become an 80S ribosomal subunit. And then your transfer RNA starts to carry over amino acids. And that's where we have some cool pictures that are in color. And it keeps happening until a termination code. And so here you go. You've seen this picture before. Again, just showing you making a copy of the single-stranded RNA. This picture shows you this spread out single-stranded RNA with all the single bases, and then the ribosomes are lined up on it. And the transfer RNAs, these things that look like fish hooks that are carrying over amino acids and lining them up on the ribosomes. And here is the process in real time, not real time because it's a static picture, but this is the real stuff blown up like a million times and stained in color so that you can see it. Here's your messenger RNA. I love this stuff. Your ribosomes. And then the transfer RNAs carrying over amino acids and lining them up. And in this picture, they look like little spaceships. Little spaceships excreting fish feces, but that's actually your emerging protein. Okay, so everything up until this point we talked about last week, but going forward we have some new things to talk about. The one thing we didn't talk about before was reverse transcriptase. Because reverse transcriptase isn't the way it's supposed to be. Reverse transcriptase is an enzyme that some RNA viruses have evolved into having as a protective mechanism. Because remember, we said that above all else, all that viruses are is genetic material that wants to survive. They have no other function in the world except survival. They want to survive. And a DNA virus can survive because, as we'll see in a few minutes, if a DNA can get into a host cell, like DNA is forever. But RNA, on the other hand, isn't forever because RNA is just a copy. So if RNA doesn't find a way to defend itself, even when it infiltrates a host cell, eventually the host defenses are going to break it down. The inflammatory response will come along and break down that RNA and get rid of the virus. When you get a rhinovirus, when you get the common cold, a viral URI, this is exactly what happens. You inhale a respiratory virus, it's an RNA virus, it gets into the cells of your airways, it screws them up for a few days, but then your inflammatory response comes along, like maybe you'll mount a fever, maybe you won't, maybe just white blood cells will migrate to the site, but your inflammatory responses will kick in and break down that RNA, and eventually that RNA, that'll be dead. That'll be the end of that, and then you'll get over your symptoms. That's why colds aren't forever. RNA viruses are vulnerable to the inflammatory response and the healing mechanisms of the host cell. But some RNA have developed reverse transcriptase, which is like the total opposite of the central dogma of molecular biology. Remember that I said the way it's supposed to go in molecular biology, it's a unipolar action. DNA is transcribed to RNA, and RNA is translated into a protein, and that's just the way it's supposed to be. But if an RNA virus wants to survive into immortality, the only way it can do it is to become a DNA. It needs to make a DNA form of itself. And since viruses are very adept at survival, some viruses have developed this enzyme reverse transcriptase. Reverse transcriptase allows an RNA virus to make a DNA version of itself. It's why it's called reverse transcriptase, because it's not the way it's supposed to be. And that's what this slide is telling you. The RNA template can be transcribed from DNA by RNA polymerase or can come from another source such as a virus. Retroviruses use reverse transcriptase to do this. A double-stranded cDNA is produced, and then it can integrate into the human genome. This is very ugly. Excuse me. HIV is an RNA virus, so this is why HIV, why we just can't neutralize it in a week or two, because HIV has reverse transcriptase. It is a reverse transcriptase virus. And all of the steps that are listed here, and in the next few slides, we're going to look at it in the form of a picture very soon, and then it will all make much more sense. But HIV-1 is reverse transcriptase. It binds to CD4 receptors. It is sucked into the cell. The viral RNA and the reverse transcriptase are liberated from their viral membrane, and then reverse transcriptase makes viral DNA from the RNA. And once you've got viral DNA, you are stuck with it forever, or until the cell that the DNA is in is killed, which, as we said, sort of violates the whole principle of trying to treat an infectious disease. Okay, viral DNA integrates into the host cell. Mutant DNA now serves as a template. It's like very ugly. I want to go to the picture because I know it'll make more sense. What does this say? As the RNA is edited to, yes, oh, this is even better. Wait, drink of water though. Not only does HIV have reverse transcriptase, but it has the code in its genetic material for two types of proteins. Regulatory proteins leave the nucleus and result in mutant protein synthesis, which makes for more viruses. Let me back that up. Which makes for the stimulation of more viruses, and then there are also structural proteins that push through the cell membrane, allowing it to go out into the surrounding environment. This really will make all more sense when we get to pictures, which is right now. Okay, here we go. And so everything I just said in the last few slides is what's happening right here. So let's put it into perspective. So here, this thin line here is your human cell membrane. This is your T lymphocyte membrane. Remember, your T lymphocytes are your cells that make T lymphocytes. That's why they're called T lymphocyte cells. And T lymphocytes help you fight infection. They are part of your immune response. So this membrane, it's a cell membrane. If you looked at it up close and personal under a microscope, you would see those hydrophilic heads and hydrophobic tails, because it's a cell membrane. The picture doesn't really show it. I mean, the membrane completely encapsulates the cell, so you can assume this is an enclosed environment, right? And so on this side of the membrane is serum. This is the extracellular environment. And on this side is the inside of the cell. So it's the intracellular fluid, or the cytosol. So here's your membrane. This is outside. This is inside. Like any self-respecting cell membrane, there are proteins embedded in this membrane. And one of the proteins that are embedded in the membranes of your T cells, your T lymphocytes, are known as CD4 receptors. And you see them sticking up here like in little green things. Got CD4 receptors everywhere. Well, let's look at these over here. This is exocytosis. So over here is your CD4 receptor, and they are characteristic of T lymphocytes, the cells that help generate cellular immunity. So these CD4 receptors have a particular affinity for the viral membrane of the HIV virus. So the HIV virus is just a virus. It's an RNA virus, so all that's in here is RNA, single-stranded RNA, genetic material. The enzyme reverse transcriptase is in here, and it's surrounded by a viral membrane. And that's all it is. There's nothing else. This little virus is not capable of eating or anything. Respiring, all it is capable of finding a way to replicate. So because you've got this viral membrane that is particularly attractive to these CD4 receptors, they will naturally merge. So these green guys will hook up with these green guys, and the virus is endocytosed into the T cell. And it's endocytosed, sucked in, the viral membrane is lost or shed. So now the viral RNA is allowed to stretch out unprotected by its membrane. All there is HIV RNA. So the RNA contains the genetic code for HIV, contains those regulatory proteins and structural proteins, and reverse transcriptase, which allows the synthesis of a DNA version of this RNA. So now you're going to make a DNA version of the genetic code for HIV. And here it is. You now have double-stranded DNA that codes for the HIV virus. And this is tragic because once you have DNA, DNA likes to be with other DNA. DNA will migrate to other DNA. So this HIV viral DNA integrates into the DNA, the human DNA, that is in the nucleus of this T cell. And there it is forever. Once it's in the DNA of the human host, you're never going to get rid of it unless you kill this cell. And one of the things about T lymphocytes is they don't die off like some of our cells, like epithelial cells, they die every few days. There are some cells that we routinely shed and just make new ones. Not so with T lymphocytes. Many of them live for decades and decades. They do divide and they do produce daughter cells, but you know what the tragedy is there? When this DNA divides, the HIV DNA is going to be in it. So the real ball buster here is when this DNA gets into the host cell DNA. Once this happens, you have HIV DNA in your cell into infinity. And then what happens? It uses the protein synthesis mechanisms of this human cell to make more copies of HIV. So now protein synthesis, just like we've always talked about it, when it's time, the DNA will separate and unwind. You will transcribe RNA copies of the code for the HIV virus. Those RNA copies will be translated into two types of proteins. There will be the regulatory proteins and the structural proteins, and these all help form new viruses. The regulatory proteins make new HIV, also make reverse transcriptase to allow this ugly cycle to perpetuate, and then they come together and the structural protein translates into an envelope that helps this new virus use the host cell membrane to push out of this particular T cell, and you have viral budding, and now you have new little baby HIV viruses all ready to go infect every other T cell that this patient has, right? So the whole thing stinks. The real problem here is that this thing has reverse transcriptase, which allows for the DNA production of this genetic material. It's older fashioned and doesn't have as many pretty colors, but what it does show you is the entire membrane. So you can see that the T cell is completely encapsulated by a membrane like every cell is. And on the outer surface of that membrane are CD4 receptors. And the CD4 receptors attract the membrane of the HIV virus. It binds and then gets sucked into the T cell. When it gets sucked in, it loses its viral membrane and the viral RNA is stretched out unprotected. Reverse transcriptase helps to produce a double-stranded DNA version of the code for HIV. That double-stranded DNA will migrate into the nucleus and infiltrate into the host cell nucleus. And once it's there, it can use typical mechanisms of protein synthesis that this T cell will use for its own DNA. Now protein synthesis will help make copies of this code. And you have several enzymes that trigger this. Nef, Tat, and Rev are the three biggies. These are the regulatory proteins. They actually just sort of keep this thing happening. Rev causes unspliced RNA to leave the nucleus. Tat stimulates the whole process of transcription. And I don't know what Nef does, but it doesn't show what it does here. Nef, Tat, and Rev, those are your regulatory proteins. And then you have structural proteins, the P24 antigen, you may have heard of that, GP120. There's a ton. There's like dozens of these things. But they all work together to help make new little baby HIVs that can be exocytosed or ejected as mature virus out into circulation to be attracted to all of the other T cells with all the other CD4 receptors on them. And this is all that the virus does. Like I said, a virus has no other role in life except to try to find a way to reproduce itself. If you look at the inside of a virus, it's just genetic material that wants to multiply. It doesn't have a nucleus. It doesn't have its own proteins. It can't even do its own protein synthesis. It doesn't do anything. All it does is worm its way in, take over, and then screw everything up. Anybody know anybody like that? I mean, think about the symmetry here between cellular life and, oh, marriage. I mean, not, I really shouldn't say that because most people are very happily married, I guess. But after husband number 4, I have a personal experience with this. This T cell is just doing great. Life is good. Everything is beautiful. You're making immunity. You're fighting off infection. Got no complaints, right? You like your job. You like your life. You like your friends. You like your house. And then here comes this HIV virus, and it's on the lookout. Its outer coat is very attractive to these receptors. You all can identify with how this goes, right? This T cell is just hanging out, enjoying life. It looks around and says, ooh, look at the membrane on that virus. It's looking pretty good. I'm attracted to it. And so it's attracted to this viral membrane. And the viral membrane finally comes in, hooks up, and then boom, it just infiltrates itself. It takes off that attractive coat. Suddenly, it's not so attractive anymore. It's just there trying to find a way to infiltrate the center of the world. And once it does, then what does it do? It screws everything up. It takes over. It starts making more of itself. It just messes up everything. It perpetuates itself. And by the same token, this cell now recognizes that something's going on there that shouldn't. It recognizes that something wrong. So your own mechanisms of cellular repair will try to fix it. So it makes you sick. It just now, what used to be a very beautifully functioning, well-adjusted, and happy life cycle, made the mistake of being attracted to the outer coat. And once it got in, it was no longer attractive. It got right in the middle of things. It screwed up everything, and now just none of it works. And the only way to cure it is to kill it. Tell me if you don't know somebody like that. And then here's just 2 more pictures of it, and we'll never talk about it again. Well, that's not true. We'll talk about it in a minute, but we'll never talk about it in quite that way again. I like this little diagram. We're going to refer to this often because it's a nice way to point to all the different areas that the HIV drugs work. And while I recognize that unless you choose to work in infectious diseases with HIV patients, you probably won't be prescribing these things on a regular basis, but you will certainly have patients that are on these medications, and you do want to understand how they work. You certainly want to understand why they're not interchangeable with other viruses, and there's other things like the adverse effects and stuff like that. So it's all important to know. But anyways, this is the same thing. I know I don't have to repeat the whole scenario to you. Virus, receptor, screws it up, and that's it. This is in real time. This is, I keep saying in real time, which isn't accurate, but this is like a real picture of a new HIV virus budding out of a cell. All right, so that's the process. Time for another drink of water, and then we'll talk about. Okay, so you can see we have some challenges here. You can see things are a bit different as compared to trying to kill a bacterial infection. Let's take a minute now to look at pharmacologic therapy. All right. So you've got a few targets of therapy for HIV medications. So these are some of our vulnerabilities. When the virus attaches, when it enters the T cell, it unwinds, it makes a DNA version. That DNA version integrates into the host cell. That viral DNA is now transcribed and translated into new HIV protein, and then it is ejected or exocytosed. 1, 2, 3, 4, 5, and 6. These are all targets of therapy. The very first class of drugs that we had to treat HIV were the nucleoside reverse transcriptase inhibitors. And in that family, there are nucleoside and nucleotide reverse transcriptase inhibitors. There are dozens of drugs in this family now, and it's not important that we tease out every one. But generally speaking, remember what a nucleoside and a nucleotide are. You have to have them to make DNA. And remember that we said one of the real killer features here of the HIV virus is that after it unwinds in the body, reverse transcriptase allows for the synthesis of a DNA version of the code. In order to achieve that synthesis of DNA, you have to be able to incorporate nucleosides and nucleotides into the emerging DNA. These drugs block that. The slides tell you what they do. Inhibits the RNA-dependent reverse transcriptase. And so these drugs can block acute infection of T cells. They can block the cells from becoming infected with HIV. Once the HIV is already formed into DNA, these drugs won't work anymore. But they can block the acute infection of new cells. So here's where they work at point 2. Inhibits the synthesis of viral nucleosides, blocks acute infection. So there certainly is a role for this. I mean, it's not as though the time frame in which this happens is really not all that clear. People can be exposed or have been infected with HIV for a very long time, and still many of their T cells have not been infiltrated. And I really don't know why. I mean, I'm not that into it that I've taken the time to try to understand it. There's many factors that determine how rapidly a cell is infected. We do know that for the most part, by the time we know that people have HIV, particularly if they don't present for screening until they're symptomatic, of course they already have some they already have some cells where the DNA has formed. These drugs won't work for them, but these drugs do help. I mean, they help markedly interfere with the synthesis of DNA. The NRTIs are the mainstay of the cocktail that you want to take post-exposure. And maybe now you can see why it is so critically important that you take them as fast as you can. If you have a needle stick from a patient that you know has HIV, or even suspect has HIV, or if you have a broken condom with somebody with HIV, or are like exposed, by way of accident or something to a bunch of blood, these cocktails can be taken up to, I think the recommendations are up to 6 to 8 weeks post-exposure. And it's because once the virus is introduced into your body, it doesn't immediately infiltrate the T cells. And we don't really know why. I don't think your handout says it actually, but what we do know, because there have been enough people now who have had needle stick exposures and then they are followed forward to see what happens. What everybody in this field generally accepts is that from the time of exposure, for some reason, the virus is essentially dormant or doesn't really do anything. It just sort of travels inertly around the body. And then some sort of signal occurs when the acute infection of cells occurs. And when that happens, the patient typically gets a flu-like syndrome. And we know this to be the case because patients classically, after exposure, somewhere like 3, 4, 5 weeks after exposure, almost everyone will develop a influenza, like a mild influenza-like syndrome. And it's believed that something happens then to trigger a high period of replication and infectivity. So the sooner the better. If you believe you've been exposed, you want to run, not walk, to the nearest pharmacy and get that cocktail. But even if you didn't do it right away, do it 6, 8 weeks out. You still want to do it because you can still block acute infection of some cells. I know it's very easy to say. Maybe some of you listening have taken the cocktail. I don't know. Blessedly, I've never knowingly been exposed to HIV, but in our line of work, it happens. A good friend of mine years ago he got stuck with a suture needle, and suture needles have little wells in them, so they have more blood in them than just like a typical, IM needle. And he was suturing a patient with known HIV, an uncontrolled viral load, actually. He was suturing this patient and stuck himself with the needle. And so he absolutely should have taken the cocktail. But at least in those days, especially, the cocktail tended to make people very sick for the short term. And he was like, you know what? I just can't take this stuff. I'm not taking it. I'll take my chances. It's hard to imagine how sick something could make you that you're willing to take your chances about being infected with HIV. But blessedly, he wasn't. And that was the end of that. But anyways, my point for you is these drugs block acute infection, so the sooner after exposure you take them, the better. But they are beneficial post-exposure. They're beneficial for weeks, and in patients with HIV, they are beneficial into eternity because there are always T cells that are not infected yet, and these medications can keep them from becoming infected. Once they're infected, though, once you have viral DNA, these drugs really aren't very helpful to those cells. Okay, next couple of pages are just the names of some of the drugs. I mean, there's so many. There's dozens anymore. I promise not to ever ask you to rattle off a bunch of names of drugs. I just want you to understand the class and how. The standard of care is to treat people with 2 or 3 NRTIs. They often work complementary to each other, even though they have the same mechanism of action. Like one medication in this class might slow down the metabolism of the next drug. So it's very sophisticated, and I don't know all of the details, so I can't tell you any more than this. But for instance, there might be one NRTI that is effective but very rapidly metabolized. Like you couldn't take enough of the drug to keep it within the therapeutic window. And there might be another drug in the NRTI class that never turned out to be all that effective, but one thing it does is block the metabolism of the other drug. So you give them together to maximize the serum level of the second drug so that it can do its job. So there are some combinations that have 2 NRTIs together, and there are some combinations that have 3 NRTIs. There was a time when Trizavir was the drug of choice in a treatment naive, in a brand new patient. You just gave Trizavir, and that was it. It had 3 NRTIs in it, and that was their treatment. But I'm sure that that's different now. Again, I just want you to understand the concepts. And so here again, here's what it does. It's NRTI interruption. Nucleoside reverse transcriptase inhibitor. It interferes with the assembly of the nucleosides, so you can't make new DNA. We also have nucleoside or NNRTIs, combination nucleoside-nucleotide reverse transcriptase inhibitors. I lost my train of thought. That's not what I meant to say. There's a non-nucleoside class. That's in the next few slides coming up. This slide is just your side effect slide of the classes of drugs we've already talked about. There are dozens of drugs in this class, and they all do basically the same thing, but the goal in making new drug is to try to make them better. The side effects of the older drugs in this class are really very profound. The newer ones are much easier to tolerate, much less of a side effect profile, but some of these things you still need to be on the lookout for. Peripheral neuropathy is one of them. The neuropathy can be really extreme. I mean, really serious neuropathic pain. It can rise to the level of having to change therapy. The NRTIs can cause drug-induced hepatitis, and we do need to be on the lookout for, if you are managing patients with these drugs, for signs of drug-induced hepatitis, like symptoms of hepatitis that is not, but when you test them for it, it's not viral. Anemia and neutropenia, and sometimes the anemia, again, mostly for the older drugs, can be very profound. The most anemic patient I ever saw from an NRTI was a patient that was on Retrovir, and this was a long time ago, but he was on Retrovir, and this was I was working in a correctional facility. This guy came down complaining that he was really tired. He just felt really wiped out. And he was on Retrovir. This guy was, under normal circumstances, like a medium-toned black guy. But on this particular day, I can't even describe the color of his skin to you. I'm not sure. Kind of like a pale gray is probably the best I could come up with. I've really never seen a color skin like this on anybody of any ethnicity or any racial group. It was just kind of like a pale gray. And his hemoglobin was 4, and it was because of the Retrovir. So of course he was tired, and of course he had, he just had no hemoglobin to give him any color. But it was, the amazing thing was that he actually was able to walk in and say, "I feel really tired." But it was from the NRTI. So these monitoring criteria, of course, these are very open to interpretation. You don't see this done for everybody, I'm sure. But the CBC, with the newer drugs, it doesn't need to be done as often because it doesn't produce as profound anemia. But anybody on an NRTI, you just want to be on the lookout for anemia. So maybe you don't work in infectious diseases. Maybe your patient's on an NRTI being followed by ID, but it's your primary care patient and comes in for like all of his primary care needs. And if you start hearing about fatigue, one of the very first things you want to look at is the hemoglobin in case he's having an NRTI adverse effect. Questionnaires for neuropathy don't have to be formal. If patients are having unusual pain for no good reason, they'll let you know about it. And then LFTs, certainly at the beginning of therapy, and if you have any real reason to suspect drug-induced hepatitis. But at the very least, at any patient encounter with patients on these medications, you do want to ask them how they feel if they're having any signs or symptoms of drug-induced hepatitis. Hepatitis can make you feel nauseous all the time. It can make you feel itchy a lot. It can make you have like a sense that your appetite is totally different than what it normally is. Just those vague systemic things are reasons to check LFTs. Now, this is what I thought I was talking about a few minutes ago, non-nucleoside reverse transcriptase inhibitors. This is another class of medication that still interferes with the synthesis of viral DNA from the RNA template, but it is not a nucleoside reverse transcriptase inhibitor. It doesn't inhibit the assembly of the nucleosides. What this class of drug does is actually bind to reverse transcriptase and stop it from doing its thing. Still interferes with DNA synthesis, but it does it differently. The upside of these medications is that their side effect profile is not as profound. The downside of these medications is that resistance can occur very quickly. These are the ones that have to be taken really on time on a daily basis. I mean, like alarm clock kind of on time. If you don't take them on time, then you can develop resistant mutations, and then that's worse pretty much than not having taken any medication at all. There are side effects. Your handout says that skin rash can be a significant one, but it doesn't seem to have quite the profound side effect profile as the NRTIs. And this talks a little bit about what I was referring to a few minutes ago about how sometimes we use one drug in a class to block the breakdown or block the metabolism of others. So again, a little repetition, inhibits reverse transcriptase activity by binding to it. And of course, again, did you get the idea that resistance can develop very fast? These are not good choices for patients where you have any concern about their ability to adhere to a regimen. Not a good idea for people who maybe have unusual work patterns or varying sleep-wake patterns, people who travel a lot, stuff like that. Here are some examples, and again, I don't expect you to know all the names by any means, just a general impression of what they do. This is another class where they are constantly developing new ones, not because it works any differently, but because they're trying to improve the weaknesses, in this case, trying to improve the likelihood of resistance. And probably some of the newer ones don't make resistant mutation as much as the older ones do. Sustiva was the first one, at least the first one I remember. Actually, I guess Viramune was older, but Sustiva is an older RTI, and this drug's claim to fame when it first came out was that it was the first HIV drug that just had to be taken once a day. And which is, when you're talking about compliance, that's really huge, a once-a-day drug. The other thing about Sustava is that one of its side effects was to cause like really vivid nightmares, and sometimes people would feel a little high from it. Both of those drugs, both the NRTIs or the NNRTIs, both block acute infection of cells. They work up here at step number 2. So it's great and the NRTIs was the first class of drug for HIV. And when it first came out, everybody was like, wow, now we finally get a handle on this thing. But remember, back then, when almost exclusively we didn't know somebody had HIV, until they were symptomatic, which means they were already immune compromised. They already had a low T cell count or a low CD4 count. So while we definitely used NRTIs to protect the T cells they had that were not infected, what we needed was a drug that could help after the cell was chronically infected. And that's what the protease inhibitors do. Protease inhibitors, remember when you put ace on the end of a word, you interfere or you stop the first part of the word? Protease inhibitors inhibit proteins. In this case, they inhibit viral protein synthesis, like right up here at step number 5. So after this has already happened and after the HIV DNA is in the patient's genome, then remember that the patient's cells, the virus uses cells' mechanisms of replication to synthesize new HIV. Protein synthesis or protease inhibitors interfere with HIV protein synthesis. So now we had a drug that could block the maturation of the virus and interfere with the ability of the T cell to make new viruses that can be spread to other cells. So this was like the other end, and everybody was so excited when protease inhibitors came out. Again, there are a ton, many that I'm sure are not described here. These are some of the older ones. These are some of the newer ones, and there are combination agents. But the thing I want you to best walk away from this with is that they block the actions of NEFTAT and REV. They block the production of the regulatory and structural proteins so that you can't make new viruses. Remember how protein synthesis occurs. You make RNA copies from the DNA template, and then those RNA copies have to be edited and then translated into a protein. And protease inhibitors block that action. These drugs can have some significant side effects too. GI distress is a biggie. These are the ones that tend to make people vomit when they take them, at least in the short term, and they can cause you some really profound jet-propelled diarrhea. So if patients can stick with them for a while, they usually develop a tolerance to it, but in the beginning, GI distress is sort of an understatement. These also can produce peripheral paresthesias and neuropathy type of symptoms, and kidney stones, and there's a bunch of other things that aren't here, like really significant dyslipidemia. Protease inhibitors can also lead to drug-induced hepatitis. These are some heavy-duty drugs because they need to do some heavy-duty work. But those three, NRTIs, NNRTIs, and protease inhibitors, they're like the standard. They're what people that are new to treatment get. They're like what virtually everybody is on. Then we've got a couple of different drugs for patients that have developed resistance to these. But the next couple of drugs are used in treatment-experienced patients. They're never like the coming out of the gate. Entry inhibitors, and sometimes these are called fusion inhibitors, these drugs interfere with step 1, right? They interfere with that attraction between the cell membrane and the viral membrane. So entry inhibitors, again, sometimes also called fusion, like the next slide. Fusion inhibitors, so they just keep the virus from entering the cell. There's just a couple of them on the market, and there may be more now. There may be another one now, but the two I'm familiar with are, check out the names. Like somebody in the marketing department of these pharmaceutical companies are either considered geniuses or they need to be slapped. These are fusion inhibitors, right? They block the entry of the virus into the cell, look at the names, Fusion and Cells Entry. I mean, this person's probably making $200,000 a year to come up with these names. Fusion was the first one. And so this is a parenteral administration. This has to be self-injected. Again, indicated for antiretroviral experienced patients. Patients who have had resistant mutation or for some other reason you need to change therapy from the classic NRTI or NRTI and an RTI or a protease inhibitor combination. Fusion is parenteral. Cells Entry was the first oral fusion inhibitor, and I'm sure that there are a couple of other ones in development now. I don't know if any of them have been approved or not. So they interfere with step one. Then we also have integrase inhibitors. We have drugs that can interfere with the integration of the viral DNA into the host cell DNA. So here at step 3, integrase inhibitors. These are also used for treatment experienced patients. These are not, starting out drugs. And everything else here is what I just said. As far as I know, there's only one drug in this class approved, but there might be others. And some of you listening might work in this field. You know more about this than I do. But the last time I checked, which I did a cursory check just yesterday before I edited this slide set. But the last time I really spent any meaningful time reading about this stuff was probably a year and a half ago, and this was very current then. Yeah, 2 others in development at that time. I don't know for sure if they've been approved or not. If you have a burning need to know, then you can check it out. All right, so those are the drugs, and there's all sorts of cocktails, and instituting them in a patient is all based on phenotype and genotype testing. It's a very specialized science now. Because there are so many different genotypes and phenotypical expressions of the virus, there are some forms of HIV that are really rather benign. Patients can have them for years and years and years and not have any significant impairment in their T cell function. And other forms are really rather virulent, and shortly after exposure or shortly after infection, patients get sick really quickly. So it is a whole science of genotype and drug selection based on that. Once you get the patient on what has been determined to be the right regimen for them, you really don't want to change it unless you absolutely have to, because when you start changing, then you do create the risk of resistant mutations. So these are some reasons to change the regimen. The first one is virologic failure. One of the main purposes of treating patients with antiretrovirals is to suppress viral replication. So if you are not suppressing viral replication, then it would appear that these aren't the right drugs for that patient. The textbook assessment of virologic failure is either if the patient doesn't respond in the first place, like after 24 weeks, they're still making too many copies, or after 48 weeks, they're even still making 50 copies. Because part of the laboratory assessment when we work up people with HIV is that we assess the viral load. And the viral load is a mechanism of viral replication. These drugs should suppress it. If they're not, this is virologic failure. Some people initially suppress and then they rebound. The virus is able to tolerate the drug. And that's another indication to change treatment. Immunologic failure is another reason to change therapy. Immunologic failure is different than virologic failure. Virologic failure means you are not suppressing virus, that the virus is replicating. What's the point of drugging the patient if the virus replicates? But immunologic failure means that you're not bouncing up your CD4 count. Your CD4 count is your measure of immune function. So the higher the CD4 count, the better your immune system is recovering, the greater immunity you are developing. We give these drugs to suppress viral replication and allow the immune system to improve. Remember, a normal CD4 count in the uninfected patient, a normal CD4 count is above 800. In a patient with HIV, if their CD4 count is above 500, they are considered clinically immunocompetent. It's like having stage 2 chronic kidney disease. It might be a little bit dysfunctional, but it's not going to bother you. If your CD4 count is between 350 and 500, this is more like chronic kidney disease stage 3. Like you definitely have suboptimal function, but probably no clinical symptoms. And then a CD4 count under 350, you are considered clinically immune compromised and susceptible to opportunistic infection. So we are totally watching the CD4 count. Immunologic failure is defined as an inability to increase your CD4 count. Or if your CD4 count falls even lower than it was before therapy, oh, that's another reason to change. And then finally, clinical failure. Some people have viral suppression that's great and immunologic improvement that's great, but they still continue to get opportunistic infection. They still continue to have clinical deterioration. And that's another reason to change. This excludes immune reconstitution syndrome. Immune reconstitution syndrome is sometimes seen in patients with HIV that start antiretroviral therapy. Remember, once your immune system starts to improve, you are capable of having an immune response. And some patients that were really immune suppressed, when you start them on antiretroviral therapy, they will develop like a febrile response because their immune system can finally work again. And it's starting to work against those things that have infected them. That's an expected response. We want, I mean, we don't want it, but we expect that. That's a normal evidence of recovery. That's not what clinical failure is. Clinical is that you continue to get opportunistic infection, even if everything else looks awesome. So that's that. I think there's one more slide here about, oh no, just a summary for changing. I did it again. I advanced the slide and forgot to stop talking. All I said at the end of that last slide was, I was thinking out loud, did we have another slide? And then I realized we didn't. So what I said is this is just a summary slide. These are your criteria for changing antiretroviral therapy. A reproducible threefold increase in the HIV RNA. This is virologic failure. Persistent decline in CD4 count. This is immunologic failure. Or clinical deterioration is where you continue to get opportunistic infection no matter what. And obviously, if the patient needs to change therapy, this should be guided by resistance genotype testing. That's all I have to say about HIV. Now, and you know, some of you may manage this and some of you may never see in a patient on antiretrovirals, but I do like that discussion because it really helps clearly describe how antiviral drugs work, and you can see how different it is from antibacterial agents. But with the next slide, we're actually going to talk about some other viral infection. And I'm going to get rid of this laser pointer. Okay, so pharmacologic management of other viral infections. Some of these may be a little more relevant to the things that you see on the day-to-day. The first one is herpes virus. Herpes viruses are the family of viruses that are responsible for shingles or herpes zoster, also responsible for HSV1 and HSV2. These are the cutaneous herpes virus manifestations that can erupt around the oral mucosa or in the genitalia. So these are due to herpes virus, and herpes viruses are different in many ways, obviously, from HIV viruses. One is that they are DNA viruses. So their mechanism of infiltration and integration into host cell DNA is similar, except that it doesn't need reverse transcriptase. Reverse transcriptase is not a factor here. So this is what your handout tells you. Herpes virus attaches to the cell membrane, just like we've discussed with HIV, but whereas HIV attaches to the T lymphocyte membrane and is endocytosed there, you know, any cell that a virus infiltrates, it's going to like screw up the function of that cell. So obviously HIV messes up immune function because it infiltrates lymphocytes. Herpes viruses infect mucous membrane cells. They're more cutaneous. So herpes attaches to the cell membrane of your mucous membrane cells and is absorbed into the cell via endocytosis. Just like we've already discussed, once it's endocytosed, it loses its membrane. The viral DNA unwinds. DNA will always look for other DNA. It migrates into the nucleus of the mucous membrane cell. And then once it integrates into that mucus, it can just make copies of itself like any self-respecting DNA can. Again, reverse transcriptase is not a factor. So let me get my little pointer here. Again, I mean, it's actually a similar phenomenon to the way HIV infiltrates. You see your cell membrane here. Again, if you looked at it under a microscope, you'd see little hydrophilic heads and hydrophobic tails, and there would be proteins embedded in here because this is, after all, a cell membrane that encapsulates a complete cell. This is inside the mucous membrane cell. This is the extracellular environment. Herpes virus comes along, it attaches to receptors, it's sucked in, it's endocytosed, it loses its coat, the viral DNA unwinds, it incorporates itself into the host cell DNA. And I realize all of these steps aren't visualized here, but it's the same phenomenon. And once it's into the host cell DNA, copies of it are made via protein synthesis. You make new little herpeses, and those new herpeses are released out into the rest of the body. There's some significant differences here. In addition to the fact that it impacts a different kind of cell, a more superficial cell, the problems that you're going to see with herpes are different. Also, remember that mucous membrane and dermal cells tend to multiply much faster. So from the time of a herpes infection, you can get a herpes outbreak pretty quickly, and that outbreak can extend pretty quickly. And then the herpes is in the cell, and it just stays there. And it may not be expressed at all, or it may be expressed a lot. It really depends on the host's immune defenses and the ability to suppress it. If you have somebody who is immune compromised, like the patient who also has HIV, when that patient has an outbreak of herpes, it can really be catastrophic because their own immune system can't suppress it. On the other hand, a patient who has a competent immune system might get infected with herpes and then have a minimal outbreak, and then may never have an outbreak again or not have one for years later. Herpes can be a little bit of a challenge, clinically speaking, because it can lie dormant for many years until something causes it to express itself. And that something is usually some impairment in host defenses, and it doesn't necessarily mean a huge disease of immune compromise. I mean, it could be the presence of an acute illness, or it could be poor sleep, or it could be taking steroids for something else. It doesn't have to be like chemo or HIV. But when immune defenses are impaired, the herpes virus will express itself and the patient will get a herpes outbreak. A couple of things that you can remember about herpes, if you want to remember anything about herpes. And again, I know I'm straying off into patient management type stuff here, but I'm sure this will be reinforced in your clinical courses. If a patient is exposed to, and I'm talking genital herpes here, if a patient is exposed to genital herpes, within 6 weeks of being exposed and infected, and I probably should even back up a little bit, almost everyone who has been sexually active has probably been exposed to herpes. But the majority of the population, their immune system will kill off the herpes before it gets a chance to infect anything. Just because you've been exposed to it doesn't mean that you will get it. There are lots of couples where they are long-term monogamous couples and one partner has herpes and the other partner never gets it. It's not that that partner hasn't been exposed, it's that their immune defenses can neutralize it. So being exposed doesn't mean you'll get it. But if you are exposed to herpes and you become infected with it, within 6 weeks you are going to have an outbreak. Some people know it, some people never do. In women, the outbreak can be internal, or it can be more posterior and not visualized, and the patient just doesn't know it. They may have noticed something feels a little weird or, a little painful. They might think it's a UTI or, whatever, and just don't ever pursue doing anything about it, and then it goes away and they don't think about it again. In men, the outbreak is typically more external. It's more easy to visualize unless the man's anatomy is such that he can't see past his abdomen, because this happens too. Same thing, he might notice some discomfort, not get overly worried about it, and then the outbreak goes away. But everybody who contracts herpes will have an outbreak within the first 6 weeks. And then it may go dormant and not be expressed again for years. Remember that you can still share herpes with somebody else, even if you don't have an outbreak. It's still contained in the cells of the mucous membranes of your genitalia. So you can give it to somebody else, and then they may or may not contract it. You might have herpes and not even know it, and you're in a relationship with somebody for 5 years, and that person never gets it because their immune system kills it off. Then you break up with that person, you get involved with somebody else, and right away that person gets a herpes outbreak. And everybody thinks, oh no, what's going on? It may be that you had it for years and didn't know it, and this is the first person you had sex with that was able to contract it. Herpes can, I mean, herpes can be rough on relationships because sometimes it shows up years later and both people think one's cheating on the other, and that's not necessarily the case. But the things you can be sure of about herpes is once you are exposed to it, you will have an outbreak. You may not know it, but you will have one. Several years ago, I had a patient call the office. He was a trucker. He was a long haul trucker, so he wasn't local. He was from Texas, actually. But he called the office and wanted to make an appointment. And when the front office person asked him what his complaint was, he said he was having some like humming sensation in his genitals. And when I looked at that, I was like, oh boy, not entirely sure what I can do about this, but we'll bring him and his humming genitals in. And he came in and he was a very large man. He was very overweight, had a big abdomen. And when he was telling me that he just had this sense of like tingling, like this weird unusual sort of kind of numbness, but not really in his genitals. And he had had it in the past, and his doctor in Texas told him that it probably came from friction of the steering wheel while he was driving the truck. And I said, well, I don't know about all that. I don't can't really think of how that relates. But all I can tell you is that what you're describing to me sounds like a herpes prodrome because, before the outbreak, there is this unusual sense of paresthesia in the genitalia. And so I had to examine the patient, of course, and there was no obvious outbreak of herpes. And I said, but it sounds like something is coming. We need to do a blood test. And sure enough, he had HSV IgGs. He had serology consistent with remote exposure to herpes from a long time ago. And so I had to tell the poor guy that, he did have herpes and he needed to take this medication to suppress an outbreak that he probably would have and wouldn't be able to visualize. And he was really distraught at the prospect of having to go home and tell his wife that he had herpes. And, it was hard. I mean, I could see where if he goes home and he says, but hey, she said to tell you that this doesn't mean anybody's doing anything wrong, that I could have had this for years. I can see his wife going, yeah, sure, right, whatever, sounds good. Usually if in a situation like that, when it's possible, I will ask the patient to bring in the significant other so that we can both sit in the office and talk about it, because you just can't get away from the fact that after your initial exposure, which you may or may not know you may not have an outbreak again for a very, very long time. But if you do have an outbreak, one thing you can count on is that there will be a prodrome of that unusual, almost kind of a paresthesia, neuropathic, neuropathy kind of thing. And that's the patient's clue that a break is imminent. And they should take there's like 1-day doses. There's a 1-day regimen of both Valtrex and Famvir that as soon as they feel that sensation coming on, they need to take it to suppress the outbreak. But anyway, this is how the virus infiltrates, and these are how it works. Okay, so these are your drugs: acyclovir, valacyclovir, and famciclovir. Acyclovir is marketed as, Zovirax. Valcyclovir is Valtrex, and famciclovir is marketed as Famvir. And they all do the same thing. They inhibit DNA synthesis via viral DNA polymerase. They inhibit cellular replication. Remember, we said there's a couple different ways that you can interfere with viral replication, and one of them is to block new viral DNA so that you can't make daughter cells. This is particularly important in herpes because herpes virus, and again, I'm talking about herpes genitalis here. Herpes infects cells that divide very rapidly. So as soon as the patient notices the prodrome, patient needs to take an antiviral immediately, inhibit viral DNA synthesis, because these cells, which will divide like in a matter of hours, less than a day, you can block the synthesis of new DNA for these new mucous membrane cells. And that's how it works. Your handout says we do have mammalian DNA, and that's true, but there's a difference between mammalian DNA and viral DNA. And blessedly, these drugs have a much stronger affinity for viral DNA. So it is safe to give them to people and inhibit viral DNA polymerase without interfering with human cell replication. But you can't get rid of herpes virus. Like Eddie Murphy used to say, you keep it forever like luggage. It's not that you can cure the virus or get rid of it. All you can do is suppress its replication when an outbreak is imminent. So here's some of the doses. Herpes genitalis, you can use all the different options. Well, for all of them, you can use all the different options. Obviously, higher doses for herpes zoster. And in terms of adverse effects, these really don't happen very often. These tend to happen in the higher doses that are needed for more aggressive forms of zoster, and even higher doses in patients who are what's the word I'm looking for? Immune compromised. Zoster especially, shingles can be really catastrophic in a patient who is immune compromised, and so they get treated very aggressively. But that's obviously something we're not going to treat. We're going to refer that to infectious diseases. Somebody who is immune compromised and then has zoster. But for your garden variety herpes genitalis, these drugs don't usually cause any significant adverse effects. And herpes labialis, oral herpes, it really isn't recommended that you do anything about that except wait it out. There are topical forms of, I can't think of the name now, but there are topical forms of Zovirax. And if it's really bad, you can use an oral, Zovirax, Val, acyclovir, something like that. But for the most part, herpes viruses in the mouth, aka cold sores, because obviously people find it much more acceptable to have a cold sore than to have herpes in the mouth. We usually just wait that out. All right, then the next class of antivirals on your handout are the neuraminidase inhibitors. So neuraminidase inhibitors are the drugs that we use to interfere with influenza replication. So the influenza virus is an RNA virus. So they're RNAs and they are not reverse transcriptase viruses. They are not capable of making a permanent form of influenza. All that the influenza viruses do is infiltrate cells, um, make copies of themselves for as long as they can until the patient's immune system neutralizes them, and then that's it, because they only exist in an RNA form. They multiply very quickly. They tend to infect cells that multiply quickly, like those that line the respiratory tract, for instance. And then, so when patients first get influenza, you probably remember that one of the features of influenza infection is that symptoms tend to come on very quickly. One of the characteristics we look for when you're trying to decide whether or not somebody has the flu is that if they woke up feeling fine, but by nighttime feel really sick, or they went to bed feeling fine and they woke up feeling sick, that's one of the hallmark features of the flu, because replication is very fast. So they get into these cells and they real quickly replicate, and then they start what's the word I want? Being exocytosed as new virions. That's what you see here. All this picture is showing you. This isn't showing you how the influenza is endocytosed. Hopefully you've got that figured out. What it's showing you is how the cell kicks out new versions of the cell. You make new virus, and then it just gets kicked out as a new virion, and these virions just replicate, and off they go into systemic circulation. And they do this by way of this enzyme neuraminidase. Neuraminidase allows the virion to multiply. We have medications called neuraminidase inhibitors that block this process, and then you just can't have this profound viral replication. This is why the neuraminidase inhibitors have to be given really early. I mean, I think the package insert says don't even bother giving it if the patient has already been symptomatic for 48 hours, and you really get your greatest punch if the patient has only been symptomatic for less than 24 hours. So for all of your patients around flu season, one of the things we do is make sure they know what the symptoms of flu are, and as soon as they notice them coming on, to immediately get into the office and get a prescription for Tamiflu. Remember that getting the flu vaccine can decrease your likelihood of getting it, but it absolutely isn't 100% protective. So even people who get the flu vaccine should be on the lookout for this. We want to give medications to block neuraminidase, which blocks virion release. The reason you want to do it early is because this happens so fast. The RNA virus doesn't survive very long. The thing that causes symptoms of the flu is that It's the patient's immune system trying to kill off all of these new virions. That's what makes people feel so bad. So if you're more than 48 hours in, this is already done. What's making you feel so sick, what's making you febrile is your immune system trying to neutralize the viruses. And it's the fever that's making you have muscle aches and headaches and all that kind of stuff, and mucousy cough if you have one or whatever. But what you want to do is block this viral release, and that needs to happen in the first 48 hours, because after that, the viruses are done. The immune system is killing them off now. What we're trying to do is block replication so the immune system doesn't have to do its job. That's the difference here. So these are several years old now, but these are the newest classes of influenza agents. We did have some older things for the flu that aren't as effective. The neuraminidase inhibitors are our most effective ones, and the most famous one is Tamiflu. They inhibit both type A and type B influenza. They can be given for flu prevention, but they are not a substitute for the flu vaccine. Definitely the CDC advocates flu vaccine is the best way to prevent the flu. We prefer to use this to suppress symptoms in people that were not immunized or who got infected despite immunization. There's Tamiflu, which is an oral version, and then there's Zanamivir, which is an inhaled version. Zanamivir is probably better because it's not used as often and there's not as much likelihood of resistance to it, but because it's inhaled, it can be a little tricky for people that have reactive airway disease. So for flu treatment, you need to start it absolutely within 2 days of symptom onset, and the sooner the better. And like I said, Tamiflu can be taken for prevention after exposure. Like if you have, a married couple in a household, neither one of them got a flu shot, and one person turns up with the flu, give the other one Tamiflu. Better than nothing. It's a chance. Tamiflu doesn't cure it. It's not like an antibiotic that kills an infection and cures the patient. What this does is to decrease the intensity and duration of symptoms by trying to block the replication of virus so that your immune system just doesn't have to do as much work. Oh, so I guess that's all of the antiviral discussion. So when you go to do your assignment for this week, if I remember correctly, it's not a classic case study, but it's a comparison or contrast or something along that order of the different agents for the flu. Like, unlike bacterial infection, where we can use lots of antibiotics for the same thing, or for different things. We can use doxycycline for genitourinary infection. We can use it for acne. We can use it for pneumonia. We can use it for skin infection. We can use clindamycin for the gut. We can use it for the skin, MRSA. We can use azithromycin for pneumonia. We can use it for acne. We can use it for sinusitis. We can use amoxicillin or augmentin for ear infections and throat infections and sinus infections, and in some cases even a UTI. Like, there's a lot of mix and match with antibiotics. That's really not the case with viral infection. Antivirals are really pretty much virus specific. And so I believe that your assignment for this week is something along the order of, why can't we use the same drugs for herpes virus? Like, why can't we use HIV drugs for herpes? And why can't we use flu drugs for herpes? Why can't we use herpes drugs for flu, and vice versa? So think about the different mechanisms of actions that we've described here and explain in a pharmacodynamics term, from a mechanism of action perspective, why these drugs are not interchangeable. All right, a few last slides here on fungus. Let me get a glass of water before we do funguses. Okay, so funguses are even different. Funguses are independent life forms. They do have little fungal nuclei, but they're not bacteria and they're not human cells. They have their own kingdom, I think. There's a kingdom fungus. So there's different targets, right? We have 3 general groups of antifungal medications: the polyenes, the azoles, and then collectively a group of others, which is some of the old stuff like griseofulvin, some of the topical stuff like tolnaftate, and then the echinocandins, which is collectively a class of very new antifungals for really more serious fungal infection. You could go a whole career and never use those, but that's the 3 general groups. So the first one are the polyenes, which include amphotericin B and nystatin. It's really kind of interesting because they are total extremes of, what's the word? Total extremes in terms of punch. Amphotericin B is very powerful. Half the time you worry about the amphotericin B killing the patient instead of the fungal infection. Amphotericin B is used for very serious infections. Patients usually do have significant adverse effects. This is like an inpatient ICU kind of medication. And again, unless you kind of do that work, you could go a whole career without seeing it. Nystatin, on the other hand, is very topical. It's very superficial. It's frequently used for candida infection, like nystatin, swish and swallow. So they're really extremes of this class of drug. But the way that they work is what's described on your handout here. Again, we're trying to kill a life form without killing the human host. So the thing to do is to find that thing about the organism that's different from the human. And in the case of fungus, like humans, fungus have a membrane. You know, um, Bacteria have a wall, humans have a membrane, funguses have a membrane. But the membrane is a little bit different. And whereas cholesterol is the principal sterol in human cell membranes, ergosterol is the principal sterol in fungal membranes. So ergosterol is a popular site of action of antifungal agents. And that's what polyenes do. They bind to ergosterol. They're kind of like fungal membrane inhibitors, just like beta-lactams are cell wall inhibitors. When polyenes bind to ergosterol, the ergosterol can't maintain the integrity of the fungal membrane. It gets disrupted, and you lose the separation from intracellular to extracellular environment. The electrolytes leak out, everything leaks out, and then the cell dies. Another difference to keep in mind is that fungal cells tend to be very slow growing, so they are slow to die. Fungal infection is typically insidious, unlike bacterial infection, or for that matter, viral infection, which can kind of hit you out of the blue, like in the course of a day. You go from being fine to being sick. Fungal infection is usually like hanging around for a long time. If you've ever had toenail fungus or athlete's foot or jock itch or something like that, it kind of creeps up on you. Same thing with more serious fungal infections. If you get a fungal infection of the lungs, like valley fever in the Southwest is not at all unusual, and it is a fungal infection. They just are sort of slow and steady and creep up on you. So the same principle applies when you're trying to kill them. They don't, when you give somebody an antibiotic, you usually know in like a solid no less than 48 hours, and often about 24, you have a sense of if there's any improvement or not. With antifungals, that's really not the case at all. Funguses take longer to go. So I mentioned amphotericin B is really heavy duty. This is a treatment of choice for these very invasive fungal infections. These don't usually happen in otherwise healthy people. These are opportunistic infections, really, that happen in people who are immune compromised or who are immunosuppressed, like on cancer chemotherapy or powerful immunosuppressants. People who are on the monoclonal antibodies for autoimmune disease are at higher risk for this. Usually there is a risk factor for fungal infection. People with uncontrolled or like undiagnosed diabetes, sometimes the first way you find out is by the presence of fungal infection. Sometimes this is how you find out somebody has HIV and is immunosuppressed, is because they present with fungal infection. So this is heavy duty stuff. Nystatin, on the other hand, this is what we use for candida. Oral thrush is a candida infection. Oral thrush is really not unusual in babies. When you get to be an adult, usually oral thrush happens with something that has impaired the immune system. Again, it's not always catastrophic as HIV, although that is in patients with HIV. We do see sometimes oral thrush and esophageal thrush. Even people that are using inhaled corticosteroids. Remember, corticosteroids suppress the immune response, and the reason that we tell people to rinse out their mouth after they use their inhaled steroid is because if they don't rinse out their mouth, there is the potential for suppression of the normal flora of the mouth and then an overgrowth of fungal infection. Also, patients that have like really large panuses, large folds of cutaneous fat, like abdominal folds and stuff like that, or large breast folds will sometimes get candida infection in those folds, and we also use nystatin. There's nystatin swish and swallow, swish and spit. There's nystatin powders. There's nystatin creams. These are the infections. These are used for candida infections. These adverse effects are obviously from amphotericin B, and they can really be profound. I mean, if you work in an ICU and you administer amphotericin B, you should do a little bit more reading about this stuff, but I suspect the overwhelming majority of you never will. It says GI upset with high doses of oral nystatin. I mean, you got to be taking some really heavy-duty nystatin. This is like the patient with AIDS, profound immune suppression, who's got refractory oral and esophageal thrush, and they're just on like large doses of this stuff. And then who knows what the GI upset, if it's from the nystatin or if it's from their HIV drugs, or just the fact that the gut can be itself impacted by HIV. This is kind of an unusual slide. It says contraindications to polyenes. It's not that the patient's going to like get sick or have an adverse event. It's just that these things are not funguses, so vaginal nystatin will not help them. Gardnerella vaginitis is one of the things that can cause bacterial vaginosis. Trichomonas is not an altogether uncommon genitourinary infection seen in women. The thing is, these things all present with vaginal discharge, and a lot of times the patient will think she has a vaginal yeast infection and ask you for the bullet, 150 milligram pill of diflucan. If anybody ever tells you they have a yeast infection, you want to look, because if you just treat for yeast without looking, there's a fair chance that it's not actually a yeast infection. And so the antifungals won't work for this stuff. Yeast has a very distinct look on physical examination. When you insert a speculum and do a visual exam of the vagina, yeast is white and it's like discrete and distinct and is kind of clumpy. I mean, sometimes there's just such an overgrowth of yeast, it's like all you can see. But other times it's just these very distinct patchy white spots. But it doesn't look at all like trichomonas, and it doesn't smell at all like BV, which is Gardnerella, because let's face it, bacterial vaginosis has that very distinct fish-like odor that just isn't yeast. So I'm probably tiptoeing into that place. I'm better off leaving to your clinical instructors here. But the point I wanted to make is that if you have a vaginal yeast infection, then yes, you need an antifungal. You need an azole antifungal. But these things are not vaginal yeast, and sometimes people confuse it that way. So you just always want to take a look. Okay, so those are the polyenes. These are the azoles. There's a whole bunch of azole antifungals. There are many topical applications available. There are some systemic applications available, and some of them are available both as systemic, meaning IV, and PO. Some of them are available systemically and topically. You can see here like ketoconazole has a little asterisk next to it. Actually, miconazole is also available in both forms, and this is not meant to be an all-inclusive list. I'm sure there are others. But the azole antifungals are probably the most common ones that you will see used, and you'll see them in enteral and topical, I shouldn't say enteral, systemic and topical form. And their mechanism of action is a little bit different. Whereas the polyenes bind to ergosterol and rupture the integrity of the membrane, azoles interfere with the synthesis of ergosterol. So here the patient can't make ergosterol. With the polyenes, they make it, but the ergosterol can't bind together. With the azole antifungals, which again are the ones you will most commonly use, the patient just can't make it. So, and this slide gives you a little more detail than you probably need on how accumulation of 14-alpha methylsterols. But the bottom line is it blocks the synthesis of ergosterol, and so if the fungus can't make new membranes, it can't grow. The significance to you is on the next slide, I think. Yes, ergosterol and cholesterol are similar enough structurally that in some cases medications that inhibit ergosterol synthesis can also inhibit biosynthesis of cholesterol. And so if you inhibit cholesterol synthesis, then you potentially have an impact on the human. This really doesn't happen very often. This is usually really high dose extended azole antifungals. Then you can interfere with steroid hormone synthesis and sterol synthesis. Notice your handout says that in some cases, this isn't very often, but in some cases, ketoconazole, which is an antifungal, has actually been used in the treatment of patients with Cushing syndrome. Because the problem with the patient with Cushing syndrome is that they have a glucocorticoid excess, they have a steroid excess. So sometimes if they are like the real treatment for Cushing's is operative to remove the cause of the excess, but not all patients are operative candidates. And so there is an option for endocrinology to give high doses of ketoconazole to try to interfere with glucocorticoid synthesis to treat Cushing's syndrome. So the point is that while the azoles are similar to the polyenes, they're different in that they inhibit ergosterol synthesis. So in high enough doses, they can interfere with human steroid synthesis, and a consequence can be a suppression of glucocorticoid like cortisol. But I've never seen it happen. Talked about it with an endocrinologist, but never seen it happen. Okay, wow, that's it. I think this is it for the entire course. I know this last week was a lot of information. Probably in some cases it was more than you really need, but learning in higher education isn't always just about what you need. It's about just what enhances your knowledge base. So anyway, I know there's a lot of information this week. Absorb what you can, apply what you can, and what doesn't click right now, maybe the next time you hear it, it will. But because I know you have a lot of information, there is no quiz this week. This material will be on your final, so I do want you to spend some time studying it. And as always, email if you have questions. Expect that you will see concepts about antibiotics and antivirals and antifungals on your final exam. But other than that, good luck.